Okay, so today's video is about lab 2 preparation, especially from a different perspective. Okay, from last three years since 2019, one thing I realize that there are couple of things that especially the Asian doctors we make those mistakes when we start the lab 2 preparation. Although I tried to clear the concept of many of my colleagues and my students, but I think it is very common, so I thought of making a video about it. First of all, I believe if you are watching this video you already know that what is Plab 2. That is the third exam after IELTS and Plab 1 if you want to get yourself registered. Basically in this exam, previously there used to be 18 station with 2 resting station. Nowadays it is 16. Okay, and with 2 resting stations you get 8 minutes for the station and you get 2 minutes to read the question. So just to give you an idea what happens on exam day, there will be 18 rooms. You will start from, let's say, room 8. You will read the question for 2 minutes and then you will enter the room and you will have 8 minutes. At 6 minutes they will give you a reminder, 2 minutes remaining. And then you will come out of the room, you will go straight to the next question, you will get 2 minutes, and this is how you move along those 16 stations. Well, that is not the topic of discussion for today. Today we will discuss couple of things that we make a mistake, especially in our preparation. The first thing, when we start our preparation, we do not get a good idea what is the course and what exactly do we need and what is the requirement of Plab 2. Rather, we get the script and we start going through the script. This is very common. To be honest, I did the same thing because I was not aware. And what happens in this type of preparation, because we are good with taking the history, examining the patient, and making a plan or management. So we go through all those stations that consists of making a diagnosis. We go through surgery, obs, gynae, psychiatry, we go through medicine. So these 5-6 sections we go through them, and it takes us 20 days when we start our preparation, because we are slow in the start. And then when we think that I am almost there and we start to get the idea what exactly is coming in the Plab 2, and then we realize that we don't know anything. Okay, so because most of the paper comes from counseling, ethical, examination, teaching, telecalls, Simman. Okay, so then we realize that we have wasted a lot of our time. So my first advice is, when you start the preparation, don't start with the stations that you are good at. We all are good at making up a diagnosis and treating the condition. Okay, start with those stations. I would say start with ethical, then counseling, then all the examinations. Okay, and in examinations I am including all those teaching and Simman as well. And then on the 4th, Peads. I will let you know later on why I am including Peads in your first part of preparation. Okay, so first point is clear. Okay, and later on we will discuss how important it is to go through these sections first, rather than your general approach going through all the surgery, obs, gynae, medicine kind of stations. Second common thing that we know about the marking criteria, okay, is that one Plab 2 station contains 12 marks, which is 4, 4 and 4. 4 is for history taking, 4 is for management, and 4 is for IP skill. Okay. So although it is right, the marking is like this, 4, 4 and 4. But there is, we are trying to improve our history taking skill, we are trying to remember the questions, we are trying to remember the management, but we are not working enough on that 4. Basically it is 6 and 6. In history you get to show your IP and you get 2 marks in history, and then in management it is again 6 marks for management, including 2 marks of IP in your management. Okay, IP is not itself a standalone thing. In those 8 minutes you do not get the time that now. Obviously for management and history you get the time now. After most of the people, they start management after the 2-minute reminder, which we shouldn't be doing that. Okay, so consider marking as 6 and 6. 6 for history, 4 plus 2 of IP in history, and 6 of management, including 4 of management and 2 of IP in the management. Okay, and so this will help us, and we can make some questions about IP. Suppose, let me give you the example of management. I believe we all are aware of air sons. It is basically a mnemonic for the management. Okay, admission or not. I is for involving senior investigations. R is for any appropriate referral. Sun is for S for symptomatic and special treatment, and then other things, next follow up, and is there any other symptom. Okay, suppose if the patient is coming with chest pain, I want you to focus on IP skill. Okay, people get the IP skill wrong. They think of it as how you dress up, what is your body language. Okay, partially they are true, to be honest, but if I sum IP skill in one word, it is the bond between you and the patient. No matter whatever you want to do to make this bond stronger, if you have a good joke, crack a joke. It should not be a lame joke. Okay, so it is basically a bond. How you can make a bond? Let me give you some examples. In management, when we start, obviously after taking the history and examination, we start by saying, I think provisionally it could be MI. Okay, now there is another debate, we should do investigation first and then we can give our diagnosis. We are not going into that discussion, okay, for the time being. So I was saying, for IP in management, the very first thing where you can clearly get 1 mark in your management for IP is to remember the name of the patient. We don't do that. The moment he is telling us the name, we just forget it. So remember the name. To be honest, once you say, suppose the condition, because you are having chest pain, based on the history, I think it is central sharp pain radiating to the back, started gradual or sudden, and it is 8/10, associated with sweating, vomiting, with the background family history of cardiac diseases. So I think it is MI. Do you know anything about myocardial infarction, John? He will remember you. He will remember you that this person remembered my name. So make sure to remember the name. And this is, to be honest, a very good, because as we just discussed, IP is basically a bond, and we can make a good bond if we can remember the name of the patient, because all of you are doctor back home, and if you can just remember the name of the patient in if it is the second visit, even if it is the first visit, if you are from Asian countries, you can say, okay, Kumar, let's see what we can do, or you can say, Amjad, what we can do. So repeating the name is a very good practice, and you can repeat it in 2-3 places in your management. the patient will understand that you are actively listening to him. Okay, this is basically a good thing to improve the IP skill. So in IP, John, do you know anything about MI? He will say yes or no based on his mood, and then we can explain. Okay, John, for this we need to do these investigations, basically troponin, routine blood cell, chest X-ray, routine blood counts, chest X-ray, and ECG. And then R is for we need to. I will involve the seniors. We may need to refer you to specialty, cardiology, or maybe acute medicine based on where you are. And then we can give asymptomatic pain relief, and then we can give special treatment. Mona, we all know about Mona. Okay, so morphine, oxygen, and glyceryl nitrate, and aspirin. So after MI, we have repeated 2 to 3 things. I will involve the senior. We need to do these investigations. We may need to refer you to a specialty. Now put another line. Are you with me, John? So basically what happens in management, we make it one-way communication, which is a wrong thing, because we know a lot of things and the time is 2 minutes. We just try to bombard patient with everything that we know, and this is where we lose marks for IP and a bond that we wanted to have. Are you with me, John? He will say yes. Okay, move on. We will give you treatment, Mona, for now. Okay, based on your if you want to go really into it, if he wants to know about the medication, it's up to you. You can go up to Fondaparinux, Tecagrelor, all those cardiology specific drugs. But for Plab 2, I would say just we will give you some medication and oxygen and painkillers to bring your pain down. Just keep it simple. Okay, if he wants to know about things, he will ask. So after telling the medication, okay, we can again put another line. Are we on the same page? So this is, and you can put the name. Are we on the same page, John? Third line, and he will say yes, I'm with you. And then you can praise him. Thank you for listening so attentively. You will move on, and then you can just complete rest of the things. I think ECG is showing STEMI or NSTEMI. If it is an NSTEMI, you can arrange a follow-up. In UK, we have rapid access chest pain clinic referrals. If the pain is not ACS, acute coronary syndrome, or if it is just a stable angina, we can refer them home. We can arrange a follow-up with the rapid access chest pain clinic. If it is ACS, like unstable angina and STEMI, we need to admit the patient, and we are explaining this. For this, we may need to admit you. I will discuss with the specialty and my senior. Here you can put the fourth line. John, am I clear enough for you, or do you want me to repeat anything? You can just say it. Try to come up with a relaxing, better sentence. You can make your own lines. So it is just to make two-way communication in your management. So now you have a good idea for those 2 marks of IP in your management, how you can improvise. Coming to the history part. So before I tell you the IP in history part, get some idea about why the patient is here. Obviously he is for management. He is there for management and not the history part. What we do, the biggest mistake we make, we try to focus on history taking more rather than management, and we take 6 minutes of our time just for asking questions. We complete Socrates, and then explore the vomiting and all the DDs, and then P3, pass medical, pass surgical. If the patient is a female, we go through periods, pills, and pregnancy, all those kind of things, and then Meftosa on top of that. Do we really think the patient is here for history? And we are spending 6 minutes for 6 marks for which patient is not there, and we are spending 2 minutes for again 6 marks, equally important 6 marks, and from patient perspective they are very important, isn't it? So now we need to think, we are spending 6 minutes on 6 marks for which patient is not interested, and we are spending 2 minutes for 6 marks for which patient is there. So we need to really balance out the time. Okay, so you are getting the idea. So coming back to the IP in history, to be honest, because there are a lot of questions, you don't really need to go into the a lot of things in IP in history. What I used to do, I did make 9 to 12 sentences which I used to practice in my practice session. Suppose because during those days we were it was allowed to shake hand. The moment I used to shake hand, if the person is muscular, I can just start with, oh, you are quite muscular. Oh, I think you used to be a gym guy throughout your life. The boys, they brag about their masculinity and their health and gym and all those kind of thing. And for the females, they feel good if someone praises their shoes or their clothing, kind of things. So first, that masculinity part, obviously now we cannot shake hands. So what we can do, the moment we enter, if it is an elderly guy, suppose 60, a very thin, obviously a lot of past medical history, but apparently he is sitting upright and he is looking quite handsome with that dressing, you can just praise him. Adam, for 60 years you are quite healthy. Or if someone, there is a female 26 year, you can enter, you can introduce yourself. I'm telling about IP in your history. Hello, my name is Taha, I'm one of the junior medical doctor, or whatever, I'm one of the specialty registrar, I'm one of the senior SHO, whatever is your job title in the question. And then you can ask their name. Suppose she is telling you that my name is Jane. The moment she is telling you the Jane, very naturally, Jane, your shoes are quite good, I'm trying to find some shoes for my sister. Okay, from where you got that? Oh, she is listening to 80 to 90 doctors on that day. I can give you in writing, she will remember you. Okay, so obviously she is, just one thing we need to make clear here. Plab 2 is not a knowledge exam. Okay, that was Plab 1. In Plab 1 they were checking your skills, you have the knowledge, you can diagnose and you can treat. Plab 2 is a communication exam. You don't know anything, they will not deduct any mark, you can call the senior. Are you getting it? So here we need to make sure that we get it right. It is a communication exam and not the knowledge exam. So how we can communicate better? We do more than a medical thing that everyone is doing. Praise their shoes. Other examples I can give, if you are aware, if there is a window, which I don't think now there is a window in the room. If there is a window, you can talk about the weather. The weather is quite sunny today. Or if then another line I made, for it was quite busy today, finally I got the time, sorry for being late, just to do something more. And then I used to praise the jackets. Oh, I'm trying to find some good jacket. Yesterday I was in town and I was not able to find, whatever, Adam, from where you got this jacket. So are you getting my point? So this will give you some leverage over other students. Okay, so now 6 and 6. IP in history, you can make 7, 8 and practice them so that it should feel natural. And then IP in your management. And then coming back to 6 minutes for 6 marks, 2 minutes for 6 marks, we should make this what should I say, how can we make this better? To be honest, even if we can cut down 20 to 30 questions, we ask usually like 60 questions in the history. If we go through that pattern, it will hardly cut 1 mark in history, and we can use that 2 to 3 minutes of time in making a good bond with the patient in IP in history and in IP in management. Okay, I can surely tell you the patient will not be bothered if you haven't completed the maftosa if the patient is coming with chest pain. The only thing in maftosa, family history. So how we can improve this timing thing? There are 60 to 70 questions that we ask in the history. Okay, and patient is not usually bothered about them. Okay, suppose we are asking all for a chest pain, we have completed the Socrates and associated symptom of dizziness, sweating, and then we moved on to doing past medical, past surgical, and then all the maftosa thing, and then coming up with the examination including chest examination and listening CVS examination. Okay, to be honest, we can literally trim down 30 questions out of those and no one will be bothered. Suppose, let me give you an example. If from maftosa you only asked family history, okay, maybe physical fitness and alcohol smoking history, okay, and leave rest of the maftosa, no one will be bothered. For suppose a TB station, okay, the only when we are going through them, there are pillar questions that we cannot bypass. Okay, so those pillar questions for TB: weight loss, sweating, productive cough long, maybe fever. Okay, and these are the questions that we can mark as pillar questions. If we want to cut down the history, we should not be bypassing those. Homeless guy, recent contact history. So these are the questions, and any travel history to areas, all those Middle East areas where TB is endemic. So these are the questions that we can make pillar questions. We can highlight them with yellow or any other color. Rest of the questions, even if we skip, that doesn't matter. For PCP, we can ask if the patient is IV drug user, we can add, and we can remove rest of the things, liver related things. So we need to make sure from every station we are removing 20 to 25 questions that are useless. Okay, for a chest pain patient, it is good practice to ask, do you have any allergies? But if you want to save the time, you can skip this, you don't need it. Okay, so this is how we can save the time when we are going through the history. When we are reading it, we can make those pillar questions. So this is how we can save the time. Coming to next part, because this is preparation from a different perspective, the first thing we discussed was get to know your Plab 2. Okay, and then get to know it is not 444, it is basically 6 and 6, and how we can improve based on those 666. Next thing is 80% of our paper comes from counseling, ethical, examination, Peads, teaching, and Simman, and we focus more on surgery, medicine, gynae obs, and all those history taking stations. We focus more on those, and 80% of the paper come from these stations, because Plab 2 is not a knowledge exam. They are not asking you to diagnose a patient, so they are shifting the trend from diagnosing stations to communication station, which are basically more of an ethical and counseling, and these stations, Peads, concerns of the mother. So it used to be diagnosing thing 2 years ago, but they have shifted it, and obviously most of the people, they don't yet know. So to start a preparation, we need to start with these stations. So this is the next mistake that we make. Okay, so 80% of the paper come from these things. If we complete these 5 sections, we have already done 80% of our preparation. What we do, we complete rest of those history stations, and when we ask someone, or if we get an idea those are the stations coming in the paper, and then we get panicked because we don't know anything what are those stations. So make sure to get this right. Next thing is, a lot of WhatsApp groups are there where people share the experience of the paper. They send a text, what happened today. So it is illegal to share paper content. Okay, so never share the paper content, but people do share their experience of the day, so that everyone should be better prepared, which is basically the idea. GMC is after to prepare you doctor for the better future. So what I would say, gather those experiences. I am gathering those experiences from October 2019, and I can surely tell you, if you have gone through last 2 months of those experiences stations, 80 to 90% of the stations you have already prepared. Okay, but if you have gone through your set of stations, it is less likely that you have completed your preparation. So it is another way of doing it. Gather those messages, prepare those first. Okay, and then you will understand every paper. 80 to 90% of the paper you have already prepared. Okay, so this is how to start. So a different perspective is to go through those experiences, 80% now, then start preparation from counseling, Simman, ethical. You are again achieving 80% of the paper, and then thinking it as 6 and 6 rather than 4 and 4. And the next thing I would say, what we do, we gather scripts of all the academies, Swami, Aspire, Samson, a lot of academies are there. And what we do when we start the preparation, the first mistake, we go through history stations and we don't practice at all. We take 15 to 20 days just going through the script alone. And a lot of those new stations that are appearing in the exam, no one has the script for that, and after 1 month of preparation we are not aware that these are the stations that exist because we don't have the script. So the best thing is to, before starting your preparation, get these things in your hand, make a plan first, and then you can go through all those 4 counseling, ethical, or examination things first, so that you should feel confident. Okay, and the next thing is, so we have discussed all those things until now. So yeah, to be honest, these were all. Yeah, one last thing, people don't usually have the idea what is scripted mean. Okay, I have discussed with a lot of students. They think if you are telling the script of Aspire notes, or maybe from the NHS site, which they don't think usually, any other notes, if you are just repeating the words, the examiner will know that you are scripted. To be honest, any examiner who is sitting there and listening to the same station 80 times a day, the very first word you open, he can clearly tell you which academy you have prepared the stations. Okay, because how many scripts are there? 6, 7, and he is listening to the station 80 times a day. But obviously, based on those things, he cannot mark you scripted. Scripted is when you remember the station and you bypass a pillar question, a pillar investigation, and you still come up with a diagnosis. Suppose if it is a pneumonia, for pneumonia we know the patient should have chest pain, fever, shortness of breath, cough, productive cough, and rest of the things they don't matter. And then moving on to bloods including infection marker, CRP, and chest x-ray. These are pillar questions, okay? And in chest x-ray we can see consolidation, and now we can give a diagnosis, confirmed diagnosis of community acquired pneumonia. This is the same thing for everyone, no matter which book you go through, which site you go through. Pneumonia is this, no matter how you explain it. The examiner cannot mark you scripted unless we bypass a pillar thing. What happened? We are going through pneumonia. From those symptoms, we know it is pneumonia, okay? There is no weight loss, and there is productive cough, chest pain, CRP is high. Somehow we missed saying chest x-ray. We didn't do a chest x-ray investigation, and we are still giving a confirmed diagnosis of pneumonia. Now he is marking a scripted. Suppose for hyperthyroidism, from history everyone knows, sweating in the hand, irregular periods, and then all those things, weight lost despite increased appetite, change in voice, becoming thinner. So from these history things we can clearly say it is hyperthyroidism. Before giving a confirmatory, before taking a confirmatory test, we are giving a diagnosis of hyperthyroidism. Now they are marking a scripted. So I believe now everyone got the point how they can mark a scripted. Don't worry about the script. Say it as it is. They cannot mark you scripted. It is the same medical knowledge all over the world, okay? So for hyperthyroidism, if you are not doing a TSH and you are still giving a confirmatory diagnosis of hyperthyroidism, now he can mark you that you remember from the script with those symptoms it is hyperthyroidism, okay? So that was the last thing. So just to quickly repeat all those things, get an idea what is Plab 2, gather those experiences, and start with the stations that are coming more, 6 and 6 rather than 4 and 4. 70% to 80% of the paper come from 5 sections, and we focus on other sections, make it right. And 80% of the paper come from last 2 to 4 months, okay? And obviously it is illegal to share papers, so try to get the experience rather than going for papers. And IP skill we have discussed so far. And one last thing, we waste our 1 month without doing any practice, and we try to complete the notes first, which we shouldn't be doing that. The moment we are going through one section, try to practice as soon as possible, because if you will start practice, you will come to know that how you can better amend your reading based on what you have learned. What happened after 1 month, then when we start practice, then we realize that I should have done this for the reading for my first section. So focus more on the practice rather than the preparatory thing. One last thing I would say, everyone knows who is taking Plab 2, whatever is coming, they know more or less about the station, okay? So don't go after a long scripts, a lot of medical knowledge, you should know all the details. No, because it is not an knowledge exam. Again I will repeat, it is a communication exam. Try to get scripts which smaller words so that you can finish them in 15 to 20 days and you can get more time to practice. Believe me, anyone with the longest notes like Hamid notes, or anyone with the smallest notes, at the end of the day they are making the same, they have the same number of words for the practice. Okay, and obviously the patient who is the actor, in the Plab 2, he will give the diagnosis in your mouth unless you are focused. Okay, if you have a good IP or bond with the patient. Thank you.